CPR for the adult. An adult is defined in being between the ages of puberty and above. When assessing the scene, assess for safety. Assess the patient. If the patient is unresponsive and is not breathing or not breathing normally, assess the carotid pulse for no more than 10 seconds. If no pulse, Rescuer 1 initiates compression-only upfront CPR at a ratio of at least 100 compressions per minute and at least 2 inches deep until the AED pads are applied by Rescuer 2. Apply the AED as soon as possible and follow the voice prompts. Switch to 30 compressions to 2 ventilations once the first analysis is delivered and once OPA and bag valve mask are ready. Switch compressors every 2 minutes. Pediatric CPR. A pediatric patient is defined as being between the ages of 1 and puberty. Assess the environment for safety. Assess the patient. If patient is unresponsive and is not breathing or is not breathing normally, assess the carotid or brachial pulse for no more than 10 seconds. If there is no pulse, perform compressions at a rate of at least 100 per minute and at a depth of 1/3 the patient's chest. Apply the AED pads and follow the voice prompts. Switch to 15 compressions to 2 ventilations once the first analyze and oropharyngeal airways are inserted and the bag valve mask is ready. Switch compressors every 2 minutes. Infant CPR. An infant patient is defined as being between the ages of 24 hours and to 1 year of age. Assess the environment safely. Assess the patient. If the patient is unresponsive and is not breathing or not breathing normally, assess the brachial pulse for no more than 10 seconds. If there's no pulse or the pulse is below 60 beats per minute, and perform chest compressions with 2 fingers at a rate at least 100 compressions per minute at a depth of 1/3 of the patient's chest. Apply the AED if the patient is 30 days old or more as soon as possible and follow the voice prompts. Switch to 15 to 2 compressions to ventilations once the OPA and the BVM are ready. Switch compressors every 2 minutes. Neonate CPR. A neonate is defined between the ages of newborn and to 24 hours post-delivery or hospital discharge. If the patient has poor respiratory effort, assist with ventilations. If no pulse or pulse is below 60 beats per minute, perform CPR, 3 chest compressions to 1 ventilation at a rate of at least 100 compressions per minute, approximately 1.5 inches deep, 1/3 the depth of the chest of the baby. Neonates do not require AED. Ventilation support is emphasized. Compression ratios are compress at a rate of 100 compressions per minute. 2 Rescuer CPR ratio for an adult patient is 30 compressions to 2 ventilations. 2 Rescuer CPR for a pediatric or infant patient is 15 compressions to 2 ventilations. 2 Rescuer CPR for a neonate patient is 3 compressions to 1 ventilation. The cardiac arrest procedure. Appropriate PPE must be worn. Team approach 2 firefighters to rapidly assess the patient. Start CPR if pulseless. Apply defibrillator. Follow the prompts. Switch compressor rolls at each analyze. Resume CPR after each analyze or shock. Assess the patient. Is the patient unresponsive, not breathing, gasping? Turn on the AED. Turn on the LifePak 15. Check for pulse. Is the patient VSA? If the patient is VSA, initiate CPR compressions while the second rescuer removes clothing and applies pads. Once the pads are on, stop CPR and press analyze. If shock is advised, resume compressions until charge is complete and machine prompts to press the shock button, at which time everyone should remain clear. No pulse check required after initial assessment unless return of obvious signs of life. Once CPR is started and the AED is applied, set up airway equipment. Insert the oropharyngeal airway, the OPA, and apply the BVM, the bag valve mask. Ventilate 2 breaths for every 30 compressions. Stop CPR if directed by EMS, a valid DNR is produced, or obvious signs of life. Patient is moving, moaning. When assessing the patient, is the patient unresponsive, not breathing, gasping? Rearrest procedure. Leave pads in place if there is return of spontaneous circulation. Check pulse every 60 minutes. Reanalyze if pulse is absent. Analyze is complete. Restart cardiac arrest procedure. Ensure your communication to EMS includes the number of shocks administered and the new arrest, not the total given shocks. Return of pulse. If there is obvious signs of life, stop CPR and check pulse. Leave LifePak 15 on and pads in place and connected. If a pulse is detected, check breathing, assist ventilations if required. Patient may breathe spontaneously through bag valve mask, BVM. Check pulse every 60 seconds. Monitor patient O2 sats, blood pressure, pulse oximetry, and temperature. Traumatic VSA procedure. Trauma is defined as obvious severe injuries to the head or torso, or a mechanism of injury likely to cause severe injury. These patients should only be analyzed once. One analyze or shock only. Ignore all subsequent analyze or shock prompts. The treatment is focused on unlikely dysrhythmias. Asphyxia arrests, as found in hangings, chokings, are not considered trauma. They should be worked as regular VSAs. Electrical arrests, such as lightning strikes and electrocutions, are also not considered trauma. On our arrival, assess. Is the patient unresponsive? Are they not breathing? Are they gasping? Turn on AED. Check pulse. Is the patient VSA? Rescuer 1 should initiate CPR only after C-spine precautions. Rescuer 2 should remove clothing and apply pads. Once pads are applied to the patient and ready to press the Analyze button, Rescuer 1 will stop compressions and let the LifePak 15 analyze. If the LifePak 15 analyzes and shock is determined, compressions are to restart until the machine is fully charged. After first analysis are indicated, resume CPR when prompted. Ignore further prompts. Leave AED on, pads on, in place to monitor quality of CPR. If the analyze prompt continues, you can press the lead button to discontinue the analyze and continue the CPR metronome. Hypothermic VSA. Key points. Pulse check should take 30 to 45 seconds to perform. If possible, remove or protect the patient from the environment. Avoid rough handling, which may cause ventricular fibrillation. The maximum amount of analyzes is one analyze or one shock only. Ignore all subsequent analyze prompts after your 2 minutes of CPR and your first analysis. Other special situations. Witness arrests by Barrie Fire or EMS, the care should focus on rapid defibrillation. Presume that there's adequate oxygen to the heart muscle. Rapid defibrillation is very important. Always assume C-spine precautions with lightning strikes and electrocutions. There is intense muscle contractions with these types of injuries. Choking, asphyxiations, and hangings. Rapid restoration of the airway and respiration are very important. C-spine precautions if appropriate. Pediatric cardiac arrest. There is no longer any age parameters. Remember that this age group generally goes into respiratory arrest first, and it causes the cardiac arrest. So good and rapid airway management is important. Based on the pediatric patient's size, ensure that there are at least 1 inch between the pads when placed on the chest. Use anterior and posterior positioning for very small patients. Parameters for pacemakers. Avoid putting defib pads near a pacemaker site. Do not delay initiation of shock to relocate pads. Safe to touch the patient whose automated defibrillator is firing. Conductive surfaces. Key points. It is safe to proceed with cardiac arrest protocols on ice, snow, wet grass, or concrete or pavement. If the patient is lying on a metal surface or in a puddle, move the patient to a suitable surface and begin cardiac arrest protocols as soon as possible. Physician on scene. State your level of certification. Provide a report to the physician. Request permission to continue the protocol. Do not assume that the physician is familiar with the LifePak 15 or more familiar with BLS than you are. Follow instructions within your protocol. Allow the physician to use the AED if he or she requests. Be prepared to take over at any time. Make sure we document the physician's name and proof that he is a medical physician. Obvious death. A vital sign absent patient of any age and one or more of the following: decapitation, transection, decomposition, gross charring, open head or torso trauma, rigor mortis. Another common sign is lividity. If the patient is found vital signs absent and after your initial ABC check or after your initial CAB check, assess the patient and look for obvious signs of death. Lividity will start to form on the back side of the patient. If the patient is in the supine position, by gently rolling the patient over, you should start to notice lividity on the bottom side. Lividity happens because of blood pooling when there is no circulation of the blood, and gravity will naturally move the blood towards the ground. Golden rules of defibrillation. Don't wait. Assess the patient, announce their vital signs absent, announce their VSA, and start chest compressions as soon as possible. Follow all voice prompts except as noted for trauma and hypothermic directives. Push hard. Rescuer 1 is the closest to the AED. Responds to the voice prompts and presses the analyze and shock button if appropriate. Switch roles at each analyze or shock approximately every 2 minutes. Push hard, push fast. Follow the metronome. Allow full chest recoil between the compressions. Minimize interruptions to compressions. Continue compressions while the AED is charging until it prompts you to press the shock button.